Hello, my name is Lee from South Korea. Today I'm going to make a short update on treating the upper tract urothelial carcinoma regarding to the perioperative chemotherapy and lymph node dissections. So about the adjuvant chemotherapy, we know that many patients after their kidney removal, more than 50% of the patients get the chronic kidney disease and with their impaired renal functions, so it is quite hard to gather the patients or recommend the chemotherapy to the patients after the removal of the kidney. So maybe it is a very fundamental difficulties to apply the adjuvant chemotherapy in the patients with the upper tract urothelial carcinoma. Anyway, so I'm going to start with these publications about the adjuvant chemotherapy. It was published in 2006 from Kwak et al. It was from the Seoul National University. Obviously, it did included just small number of the patients, 40 patients for total. But we can see there are significant differences and benefits on the adjuvant chemotherapy in both disease-free survival and overall survival. And 2014, there was a meta-analysis about the adjuvant chemotherapy, but we can see this study only included 3 studies about the adjuvant chemotherapy which used cisplatin, and another 2 studies was included with the another regimens for the adjuvant chemotherapy. Overall, there was no differences and no benefit was observed from the adjuvant chemotherapy in this meta-analysis. However, if we look into the subgroup analysis of the studies which used the cisplatin only, there was significant benefit from the adjuvant chemotherapy, and the p-value was 0.02. This was the first meta-analysis about the adjuvant chemotherapy in the patient with UTUC. And after a few years, in 2017, Sainsen et al. Performed a nice analysis about the adjuvant chemotherapy in UTUC, and they analyzed the big database from the US, the National Cancer Database, and they included more than 3,000 of the patients, and they found that there was a significant benefit in the adjuvant chemotherapy groups in terms of overall survival. And finally, last year, we have the level 1 evidences about the adjuvant chemotherapy in UTUC. The name of the trial was POT trial, and they included a patient who has T stage more than 2 and positive lymph node. They performed the chemotherapy within the 90 days after surgery using cisplatin or carboplatin based chemotherapy, and in their study there was no differences between the pathological T stage and nodal stage. In their study they found that there was a significant longer disease-free survival in the adjuvant chemotherapy group, and the hazard ratio was 0.45 and the p-value was under 0.0001. And also they found that there was a significant differences in terms of the metastasis-free survival favoring in the adjuvant chemotherapy arm. Hazard ratio was 0.48 and the p-value was very low. And 2020, now we have the updated meta-analysis about the adjuvant chemotherapy in the patients with UTUC. So this paper analyzed more than 15 studies about the adjuvant chemotherapy. There was a significant number of retrospect trials about adjuvant chemotherapy, and also there was 2 studies which was performed by a prospect trial, and they found that there was a significant benefit from the adjuvant chemotherapy in the patient with UTUC. So now we got the recommendation about the adjuvant chemotherapy in the NCCN guideline. So they recommend if the patient has higher T stage, more than T2, and if there is a positive lymph node from the lymph node dissections, then they recommend to perform the adjuvant chemotherapy in those patients. Okay, from now we are going to talk about the neoadjuvant chemotherapy. So we all know that the neoadjuvant chemotherapy has better benefits for the patients, for the tolerance for the chemotherapy, because there are high chance for the normal renal functions compared to the adjuvant chemotherapy group. However, still now there is only small studies with the retrospective analysis. So this paper has been published in 2010, and they only included about 40 patients, and their chemotherapy regimen was not unified. However, they found that the tumor size was successfully decreased about 50% before and after the chemotherapy, and about the 50% of the patients get the complete remission or the partial remission from the neoadjuvant chemotherapy. Another study has been published in 2014, and they included 29 patients with the neoadjuvant chemotherapy and 66 patients with the surveillance, and they found that there was a significant differences in the postoperative T-stage classification, which means there was a significant downstaging from the neoadjuvant chemotherapy. And also they found that the non-invasive percentage of the patient who has the non-invasive non-invasive UTUC was significant different between the two groups in this study. And also those differences were successfully connected to the superior survival outcomes in those two groups. So we can see a good gap between the disease-free survival and the overall survival in this study. And in the multivariate analysis, the neoadjuvant chemotherapy was successfully predicted for the longer overall survival and also the disease-specific survival. At 2014, there was a meta-analysis who dealt with this neoadjuvant chemotherapy. However, this study just included two studies, which is also the retrospective small studies. So the evidence was not so high, but they found that there was a significant benefit for the neoadjuvant chemotherapy. And after 6 years, the last year in 2020, now the meta-analysis was revised, and they analyzed 16 studies about the neoadjuvant chemotherapy, and there was a significant benefit in the neoadjuvant chemotherapy. Okay, from here we are going to talk about the lymph node dissection in the patient with UTUC. This paper is published in 2009 from the Severance Hospital in Korea, and they found that the patients who get the lymph node dissection had superior outcomes in terms of the recurrence-free survival compared to the patient who did not get the lymph node dissections. However, there was no differences between the number of the harvested lymph nodes. You can see there is no difference in the upper part of these two curves. This study was performed by Martin et al. It was published in 2015 in Journal of Urology. They analyzed the 73 patients who received the lymph node dissection, and the patients had diagnosed with positive lymph node in their pathological specimen, and they analyzed the distribution and the location of the lymph node, positive lymph node in those patients as according to the original location of the primary tumor. So when you look into the figure A, the left side, when the tumor was located in the right renal pelvis, then the positive lymph node was found at hilar and paracaval and retrocaval and outercaval lymph node. And when the tumor was located in the left side upper renal pelvis tumor, then the positive lymph node was located in the supra and hilar lymph node and para-aortic lymph node and common iliac and aortic bifurcations, and also outercaval lymph node was found. And when we look into the figure C, That means the tumor was located in the right side upper ureter. Then the lymph node was positive in hilar and paracaval and retrocaval lymph node. And in the case of the left side upper ureter tumor, then the lymph node was in the hilar and para-aortic lymph node. So they suggested some template for the lymph node dissections according to the primary tumor. So when the tumor is located at the right side, renal pelvis and upper ureter, then they suggest to perform the lymph node dissections in hilar and paracaval and retrocaval. That will cover the 92% of the positive lymph node. And if you perform the additional lymph node dissections in the inter-outcaval lymph node, then you can cover the 95% of the positive lymph node. And if the tumor is located in the left side, renal pelvis and upper ureter, then you should perform the hilar lymph node and para-aortic lymph node that will cover 86% of the positive lymph node. And when you perform the additional lymph node dissections to the outcaval lymph node, that means you can cover the 90% of the positive lymph node. And if the primary tumor is located in the mid-ureter and the low ureter, then you should extend your lymph node dissection to the common iliac arteries and internal iliac arteries to cover the positive lymph node dissections. But unfortunately, we only have the small studies about the lymph node dissections in the patients with UTUC until 2019. And all the studies were retrospective, and there was no study with prospective trial. But in 2019, Dong et al. Performed a nice analysis using the SEER database from the US, and they found that there was a significant differences in overall survival and also in the cancer-specific survival between the patient with or without the lymph node dissections. And we know, this study was also the retrospective analysis, so they performed the propensity score matching analysis to adjust the differences between the preoperative variables between the two groups. And after the propensity score matching, the significant differences between the two groups was consistent in both overall survival and cancer-specific survival. Even though we don't have relevant evidences until now, but the European Urological Associations, they recommend to perform the template-based lymph node dissections in patients with suspicious muscle-invasive urothelial cancer. And the recommendation strength is strong. This is the end of my presentation. Thank you for listening.